You ever wonder how a doctor can listen to someone's symptoms and figure out the exact spot of an injury deep inside the brain or the spinal cord? It feels like some kind of magic trick, right? But it's not magic. It's straight-up detective work. It's a process of deduction called neurologic localization, and today we're going to learn how to crack the case.
All right, let's just jump right in with a classic neurological mystery. Real head-scratcher. Imagine this. One side of your body is weak, you can't move it well, but the other side of your body is numb. It just sounds impossible, doesn't it? A total paradox. But believe it or not, solving this exact puzzle is the key to understanding how doctors hunt down problems in the incredibly complex wiring of our nervous system.
So our investigation is going to start at crime scene number 1, the spinal cord. You can think of this as the main information highway connecting your brain to the rest of your body. And to solve any case here, you have to know how to read the clues, the telltale signatures that an injury leaves behind on the major pathways running through it.
Our first key witness is the corticospinal tract. This is the superhighway for movement, simple as that. When you decide to pick up your phone or walk across the room, the command from your brain zips down this very pathway to make it happen. So any damage here, well, that means weakness or even paralysis.
Next up, we've got the dorsal columns. Now, these pathways handle all the high-definition sensory info. We're talking about things like feeling the texture of your clothes, the buzz of your phone vibrating, and this incredible thing called proprioception, which is basically your brain's built-in GPS that knows exactly where your arms and legs are in space without you even having to look. And our third major pathway is the spinothalamic tract. This one is all about those raw, fundamental sensations that keep us safe, pain and temperature. Now, you're going to want to pay very close attention to this tract because the unique route it takes through the spinal cord, that's the critical clue that's going to solve our opening mystery.
Okay, what you're looking at here is basically a decoder ring for spinal cord injuries. It's fascinating. Different injuries create these unique telltale patterns. An injury to the front of the cord knocks out movement and pain sensation, but somehow leaves fine touch totally fine. An injury to the back does the exact opposite. But the most famous one, the one that cracks our case wide open, is Brown Sequard syndrome.
And boom, here it is. This is the solution. With Brown Sequard, where just one half of the spinal cord gets damaged, you lose motor control and fine touch on the same side as the injury. That makes sense, right? Those pathways just run straight down. But, and here's the twist, you lose pain and temperature sensation on the opposite side of the body. Why? Because that sneaky spinothalamic tract crosses over to the other side almost immediately after it enters the cord. Case closed.
Okay, so that's the spinal cord. Now let's move on up into a much more complex, high-stakes area, the brainstem. This is the dense, absolutely critical junction box that connects the brain to the spinal cord. And to navigate this place, neurological detectives have a secret weapon, something called the Rule of 4.
You know, the classic fingerprint of a brainstem problem is a pattern called crossed signs. And this should sound pretty familiar by now. It's when a cranial nerve problem, something like a droopy face or double vision, shows up on one side, but the weakness or numbness is on the opposite side of the body. When a doctor sees that specific pattern, alarm bells go off and they know, for sure, the culprit is hiding somewhere in the brainstem.
So, how does this rule of 4 actually work? Well, it's a brilliant little mnemonic. First, it tells us that all the important pathways running down the middle of the brainstem start with the letter M, and these are mainly your major motor pathways. Then, everything on the side of the brainstem starts with an S, and these are mostly sensory pathways. It's a simple trick that immediately helps a doctor narrow down which side of this tiny, packed area has the problem.
Now, the second part of the rule is what helps us find the exact level of the problem, up or down. There are 12 of these critical cranial nerves, and the rule says to just divide them by 4. So if the problem is with nerves 3 or 4, which deal with eye movements, the issue is high up. If it's nerves 5 through 8, affecting your face and hearing, the lesion is in the middle, in the pons. And if it's nerves 9 through 12, messing with the throat and tongue, the problem is down in the medulla. It's literally a neurological GPS.
Okay, for our final case file, we're moving up to the main control center itself, the cerebral cortex. Now up here, the detective's strategy has to change a little bit. Instead of just tracking individual nerve pathways, we often follow the blood supply. Why? Because strokes, which are blockages of blood vessels, tend to affect the specific territory that's supplied by just one artery.
And this map just lays out the evidence perfectly. Let's say a patient suddenly can't move their face and arm, but their leg is totally fine. The detective knows the culprit is almost certainly a blockage in the middle cerebral artery, or MCA, which controls the side of the brain. But what if only the leg is weak? Well, that points directly to the anterior cerebral artery, the ACA, which feeds the midline. And if the patient suddenly loses vision in part of their visual field, the trail leads right to the back of the brain, to the posterior cerebral artery. The pattern of weakness is like a direct map to the blocked vessel.
But, every good detective story has to have a twist. What if the symptoms are all over the place and they don't point to one specific spot? Well, sometimes the culprit isn't a single lesion like a stroke or an injury. Sometimes it's a systemic problem, an imposter that's just disguised as one.
Take these two, for example. They are classic imposters, vitamin deficiencies. A lack of vitamin B12 can cause numbness and balance issues that can look exactly like a spinal cord injury. And a thiamine, or B1 deficiency, which you often see in conditions like chronic alcoholism, can cause a really dramatic syndrome. Catching these is absolutely critical, because unlike a stroke, these problems can often be reversed with treatment if you catch them early enough.
This is the classic triad of Wernicke-Korsakoff syndrome, and it's a true medical emergency. It usually shows up in this very distinct three-step pattern. First, problems with eye movements. Second, ataxia, which means they have a lot of trouble with balance. And finally, confusion. When a doctor sees that 1, 2, 3 punch, they know they're not looking for a stroke. They're looking for a body-wide deficiency that needs urgent thiamine to prevent permanent brain damage.
So, when you boil it all down, here's the crucial point. Neurologic localization is a systematic process. It's about matching the pattern of symptoms, all the clues, to the known anatomical pathways in the body's wiring diagram. Whether it's those crossed signs in the spinal cord, the rule of 4 in the brainstem, or the arterial territories in the cortex, the clues are all there. The doctor's job is to be the detective who knows how to read them.
So we've spent this time learning how these incredible detectives of the nervous system find the where. But, as any investigator will tell you, just finding the location of the crime is only the first step. The real mystery, the one that actually leads to treatment and recovery, is figuring out the why. And that, well, that opens up a whole new investigation.